Next, we'll invite Dr. DEEPAK MEGUR for his topic is pseudoexfoliation and small pupil. And of course, Dr. DEEPAK MEGUR requires no introduction. His videos are all over the YouTube, and it's been educational for all of us. Dr. DEEPAK MEGUR, please.
Thank you, Dr. Suven, for having me on this course. I'll be speaking on pseudoexfoliation and small pupil. As we all know, pseudoexfoliation is extremely common, and we almost every third or fourth case in our OT list would be having this. And the material is deposited across the anterior segment structures from the anterior capsule to the zonules. Display, mirror. Okay, is it on now? Okay, so pseudoexfoliation is extremely common, I think. As we all know, every third or fourth patient in our OT list would be having this, and we see these pseudoexfoliation material placed all over the structures in the anterior segment, apart from the anterior capsule to the zonules, etc. And it has got certain impacts on the iris as well as the zonules. So traditionally, we have had many ways to deal with this pore mydriasis in these eyes, starting from using just the intracameral dilating agents, which are now available with a combination of topicamide and lidocaine, phenylephrine. And they work to a certain extent. One advantage is they might prevent a little bit of an intraoperative miosis, but their action would be limited. They don't give you consistently a well-expanded view. And obviously, the stretch pupilloplasty had been our go-to the mechanism for many years now. And we used to stretch up to the limbus to ensure that the sphincters get torn, and then that would ensure that the pupillary mydriasis was maintained throughout. The only issue was post-operatively you would be having a slightly bigger pupil and slightly disfigured. Of course, we also used to resort to this microsphincterotomies, wherein used to be giving a small sphincterotomy, just about maybe 0.5 micron in the pupillary margin. And then the only disadvantage is the dilatation would not be great, but you could prevent intraoperative mydriasis. And if you're very careful, there is not much of a disfigurement as well. But these are the days when we did not have pupil expansion devices, and the iris hooks have been the gold standard for many years now. And the tip is always to make the side port incisions very, very short in length, so that we don't lift up the iris. Capsule hooks are another one which I use whenever there is an associated zonular weakness as well as pseudoexfoliation. Capsule hooks are the better option instead of other things. Now, coming to using a ring-based, pupil-based stretching rings, in these rigid pupils which are associated with pseudoexfoliation, it's mandatory that we have some sort of an expansion. So initially, we were doing up to the level of the limbus. You don't have to do that now. Important thing is, whenever the lens is swollen, inject a little bit of viscoelastic underneath the capsule, so that we don't damage the anterocapsule trying to manipulate the ring inside. So that is one small trick, because in many of these cases, the intumescent lenses, the lens will be very swollen. So during the manipulation, the forceps which are using to push in the thing, that itself can puncture the capsule. Just lift up the iris a little bit by using very little amount of OVD, and then you can manage. A trick again here is to always stabilize the globe with the second instrument. This ensures that the globe is not turning around and you're seeing well, so that you can implant the ring quite easily. So usually 5.5 millimeter is the expansion which you get with this device, and it is really good enough for majority of our situations. And it also acts as a template for us to get the sizing and centering of the rexus right. So it actually, you can get a perfectly sized 5 millimeter rexus. And most pseudoexfoliation cases also have associated zonular weakness. And whenever I'm dealing with a denser cataract like this, I would always like to stabilize the bag early enough by placing the CTR early enough, not waiting it to be put later. So just create a little bit space under the capsule by using OVD, and then you can manipulate the CTR very well into the bag. And all this is possible because we can see well because we used a pupil expansion device. The nucleus division techniques can be of your choice, the whatever technique you can use. But once the pupil and the visibility is taken care of, the case essentially becomes a routine one. So you can focus on other things like, taking care of the zonular laxity and other things. So the importance of seeing well cannot be overemphasized. So I am a little bit, my threshold is very less whenever I would want to start using a pupil expansion device just for this. Of course, we can do without using any devices, but it makes the surgery a little bit more safer. This is another one case where you can see a very small pupil, dense cataract. Again, a very little bit of OVD. Mind you, you cannot push a lot of OVD here because there is another side effect which can happen. This can go across the zonules into the burger space and create a sort of a misdirected syndrome, because all these pseudoexfoliation eyes have got a compromised zonular barrier as well. The fluid can carry across this. So be a little bit careful. Don't push in a lot of fluid or OVD, including dye. Even dye has the ability to percolate across. Just use very little of the fluid, because this one concept we need to be careful of. Majority of this will have an anterior halar detachment as well. So these can give us posterior misdirection, fluid misdirection, and cause an intraoperative shallow chamber and other sequelae, which can be challenging to manage in these situations. So once because the stretching, stretching is mandatory for these cases, because these are very rigid pupil. Unlike what we see in IFIS, where stretching is in fact contraindicated. So once again you are seeing well, things will become as if routine. Nothing normal about this case, and all the steps will become routine. My only request to Suven would be, I would want to have a colored BX ring, because what happens, in these eyes, in the camera it looks well because I adjust a little bit of a contrast and all. In eyes with pseudoexfoliation, the cornea is hazy, IC is very shallow, the BX ring and the iris are the same color. Sometimes we don't know whether your notches have engaged the iris or not. How I wish you could have something like a green, which is totally out from our iris. So that is one thing which I would
the material,
see that if it is possible.
This material comes only in this color.
Yeah, that's the only thing.
A big problem.
So that is one thing which is this thing. So what are the potential limitations? Arup sir beautifully told that there are many advantages of using iris hooks, certainly. But in certain situations, my situations, I do prefer iris hooks in certain cases, difficult situations where you demand a larger pupil. So because especially when I have a rhexis which has gone radial, I want to see the peripheral part. And we have a peripheral, PC tear sometimes. In those situations, even if I put in a BX ring, I would remove and then put a iris hooks like this and convert to SICS. This is a situation where I would convert an SICS, and hooks do a great job here. So these are certain situations where we have to be, having the stock of your iris hooks as well. Now, this is a case where we have created a peripheral postcapsular punch, and it is not visible through the 5.5 millimeter pupil, which I always have. So in these cases, I would like to always prefer to use a hook so that I can stretch it to the limbus and see exactly where the postcapsular tear, and ensure that that does not enlarge, and I can still go ahead and implant my lens in the appropriate place. So other than that, I think nowadays, the last maybe 5-6 years, we are blessed with a lot of pupil expansion device that has made our surgery safer and simpler. Thank you so much for the opportunity.